was built to last. When the webs are weaving, I could change the past. With all of the
Hello everyone, welcome back to the channel. We're here today. We're going to go over a very high yield educational objectives for hematology and oncology related to the ABIM boards. We're going to be creating our own questions using GPT-4o, and then we're going to go through all the options, and I'll show you how else the same question can be tested multiple times. The notes from this video will be available in Patreon, so you can use those notes to create more questions with your own GPT engine. This is going to be on GPT-4o. We're going to basically add more engines and try them out. Basically, I've been using and testing this method out for about a month, where I've been creating an instruction that I give it to create these questions in a certain format, and then I've been also giving it some instruction of how to break down the questions and answers and how to explain them. And by watching these videos, you're going to get used to those, and you'll also be able to make your own instructions that tailors to your kind of studying. But so let's get into it. This is a 65-year-old man who undergoes a major thoracic surgery and receives a heparin for venous thromboembolism, VTE prophylaxis. He is discharged without complications but presents to the emergency department 10 days later with progressive dyspnea, swelling in his right leg, and a new deep venous thrombosis on ultrasound. The labs reveal a platelet count of 55,000, which is down from his discharge that was on 210,000. He reports no recent heparin exposure since hospitalization. Which of the following is the most likely diagnosis? So go ahead and pause the video right here, pick your answer, and then we're going to go through the options together. All right. So let's talk about pathophysiology. So this most likely is going to be the heparin-induced thrombocytopenia. It's called a delayed onset in this case. It is an immune-mediated disorder caused by antibodies against the heparin platelet factor 4 or PF4 complexes. This reaction triggers the platelet activation and thrombosis despite a low platelet count. Unlike classical HIT, the delayed onset HIT occurs about 5 to 19 days after heparin cessation due to persistent circulating HIT antibodies. The first option was disseminated intravascular coagulation, or DIC. This typically presents with a consumptive coagulopathy, leading to prolonged PT, PTT, elevated D-dimer, low fibrinogen, bleeding from IV sites, and just bleeding in general. This one, delayed onset, is the correct answer. The patient presents with a 5 to 19 days after heparin cessation with thrombocytopenia, new thrombosis, which aligns perfectly with the pathophysiology. APS, this would be the antiphospholipid syndrome. This can cause both arterial and venous thrombosis. Does not cause thrombocytopenia in that same time frame as HIT. APS diagnosis also requires recurrent pregnancy loss or some sort of a lupus anticoagulant or anti-cardiolipin antibodies, which are not mentioned in this question. And then the ITP, which is an autoimmune disorder, isolated thrombocytopenia, but without thrombosis. The presence of a new DVT makes ITP very unlikely. So as you can see, how many ways boards can really make new questions. Every answer option could be a board question on its own, and you really can generate more questions to really solidify this topic in your brain. So let's go ahead, and the last one was a warfarin-induced skin necrosis. Remember, this one is related to a protein SC deficiency. Patients shortly after warfarin initiation will develop this skin necrosis, which is horrific, and it's not really a thrombosis, so this doesn't make sense. All right, so when you see suspect delayed onset HIT, if a patient develops thrombocytopenia and thrombosis 5 to 19 days after heparin exposure, use the 4T score to assess the HIT probability, and you can use that on MD-Calc. If HIT is suspected, immediately stop all heparin products, including the LMWH or Lovenox. Initiate a non-heparin anticoagulation such as argatroban, bivalirudin, and fondaparinol. Confirm the diagnosis with HIT antibody testing with an ELISA or the serotonin release assay. And avoid warfarin until platelet counts go up greater than 150,000 due to that risk of venous limb gangrene. Okay, so again, so much clinical pearls and board pearls in that algorithm. The pattern recognition, just realizing the thrombocytopenia and thrombosis, which occurs after a few days after stopping the heparin, thinking about the delayed onset HIT, and the timing is very high yield. The platelets drop below 100,000 plus a new clot formation, which suggests this immune suspicion, immediate suspicion, which suggests this immune reaction. The immediate action is to stop all the heparin products, start a direct thrombin inhibitor, and do not start warfarin until platelet recovery. HIT antibody testing you can use to confirm, but do not delay the treatment. Long-term anticoagulation would be at least 3 to 6 months if thrombosis is present. And the answer is delayed onset HIT. As you can see, we did a really good job on how it broke it down in certain ways and structured it out for you based on my instructions. So go ahead and let's get started with the second question. So this one is a question number 2. So a 52-year-old woman with a history of atypical ductal hyperplasia is taking tamoxifen for breast cancer risk reduction. She's scheduled to undergo an elective total hip arthroplasty. In about 3 weeks, she has no personal history of VTEs or clotting disorders. What is the best next step? So it seems like the question is all about when to stop tamoxifen. So let's look. Continue tamoxifen throughout the perioperative period. Discontinue tamoxifen 1 day before the surgery. Discontinue tamoxifen 2 to 4 weeks before surgery. Switch tamoxifen to raloxifene prior to surgery, or continue tamoxifen and add prophylactic anticoagulation. I'm going to pause the video right here, pick your answer, and then we're going to go through the options together. All right. So tamoxifen is a selective estrogen receptor modulator, or a SERM, that has an anti-estrogenic effect in the breast tissue, but pro-estrogenic effects on the endometrium and the coagulation system. It increases VTE risk by promoting a hypercoagulable state, particularly in patients who are immobilized post-operatively, who basically have a highest VTE risk. The highest VTE risk usually occurs within the first 2 years of the therapy. Now, for high VTE risk procedures such as a hip arthroplasty, tamoxifen should be stopped 2 to 4 weeks prior to surgery. And this is the question that was trying to test you on. So option A is set to continue. That would be wrong. Discontinue 1 day. That would be too short. And discontinuing 2 to 4 weeks would be the right guideline recommended approach. And then switching to raloxifene. So raloxifene is another SERM, also increases VTE risk and is not safer compared to tamoxifen in this aspect. And then continuing tamoxifen and adding anticoagulation, that would be incorrect. Some prophylactic anticoagulation is used postoperatively. It does not eliminate the need to stop the tamoxifen perioperatively. And the algorithm about thinking about tamoxifen, just remember, in patients scheduled for a major surgery, especially high-risk surgeries, stop at 2 to 4 weeks. And if they're low risk, like a minor outpatient procedure, you can continue. Post-operatively, tamoxifen can be resumed once the patient is ambulatory and a low risk of VTE presents. And going through pattern recognition, whenever you see a question about tamoxifen, surgery, and immobilization, think about the VTE risk. If it's a high VTE risk, stop the tamoxifen 2 to 4 weeks before. And the latest guidelines, patient on tamoxifen for primary breast cancer prevention should stop it 2 to 4 weeks before high VTE risk surgery. And for cancer treatment, oncology consultation needed before stopping. Correct. So just don't, if you're a primary care physician, don't stop it without telling your oncology consultant. And then tamoxifen can be resumed post-operatively once the patient is ambulatory or low and low risk for VTE. So that was the correct option. So this will be going to now the third question. If you've enjoyed the video up to here, you're liking these questions and how high yield and important the information are, please drop a like, maybe comment, subscribe to the channel. Let's do this together. All right, question number 3. So this is a question of a 72-year-old man who has history of AFib and he's on warfarin therapy. He presents to the emergency department for routine blood work. He reports no symptoms of bleeding, bruising, or neurologic deficits. His INR is now 7.2. And then when you review his medications, I mean, he's on warfarin, amiodarone, lisinopril, and atorvastatin, and these were all started 2 weeks ago. And so, what is the most appropriate next step in the management of this patient? Go ahead and pause the video right here, and we'll go through the options together. All right. So this is a question about warfarin, right? And a patient that is supratherapeutic with his INR. So warfarin inhibits the vitamin K dependent clotting factors 2, 7, 9, and 10. Remember, leading to a prolonged INR. Many factors can increase the INR, including drug interactions, one of which was here the amiodarone. There could be also antibiotics, NSAIDs, liver dysfunction, or someone with vitamin K deficiency. The management of an elevated INR depends on degree of the elevation, if there's any active bleeding, and if the patient has high bleeding risk. So this question, the first option said administer IV vitamin K. So IV vitamin K is reserved for serious or life-threatening bleeding due to its rapid action. The patient has no active bleeding, so IV therapy is unnecessary. Starting PCC. PCC also used for life-threatening bleeding. In urgent INR reversal, the patient is stable and does not require it. Holding warfarin and giving low-dose oral vitamin K. So that's the correct answer. His INR is between 4.5 and 10, and there's no bleeding. So we can hold the warfarin and just give a low dose, which is between 1 and 2.5 milligrams of vitamin K orally in patients with a high bleeding risk. So if somebody has, for example, a history of GI bleeds, fall risk, they're elderly, and I think this patient is, has some of that. He's elderly, he has high bleeding risk, he's on NSAIDs or not, lisinopril. So he does not have any history that suggests that he has high risk, but he is still fall risk because of his age. So he could bleed. So for this patient, this is the best answer. And then hold warfarin only. This partially correct, but not the best answer. Remember that the INR of 4.5 to 10 without bleeding, we generally managed with both holding the warfarin and adding a low dose oral vitamin K. And then discontinuing warfarin, switching to drug, that would be incorrect. The INR elevation is due to drug interaction, not a contraindication to warfarin. So that makes sense. And then here's the algorithm. If the INR is less than 4.5, hold the warfarin or adjust the dose. If the INR is 4.5 to 10 with no bleeding, you can do you can hold the warfarin and do oral vitamin K if the patient has high bleeding risk. If INR is greater than 10, and there's no bleeding, you still have to give the oral vitamin K and hold the warfarin. If any INR with active bleeding, you have to urgently reverse with IV vitamin K at PCC or FFP. And always try to identify the cause. What is causing it? Is it a drug-drug interaction? Is there a liver disease? Is there any dietary changes which could cause vitamin K deficiency? Restart warfarin at a low dose once INR, lower dose once INR normalizes. Okay. And then right here, just kind of puts it back all together for better visual presentation. The guidelines, again, I agree with what we just talked about. And the answer is hold warfarin and give low dose oral vitamin K. All right, so we're at the end of our session here. I hope you guys are really enjoying these videos. We're trying to make them fast, easy to understand, and only tackling high-yield educational objectives from ABIM. If you're enjoying the video, make sure to follow. You can follow me on Instagram as well. Subscribe here, like, whatever you need to do. Download the summary notes for each session on my Patreon and get started with creating more of your own board questions, which we basically be able to tackle more and more. But I'm going to try to basically scope out all of the high yield material for you, and so that we can go through them together. All right. I'll see you on the next one.